Dorothy Matthews is a 75-year-old female patient, weighing 62.3 kilograms with a height of 5 feet and 2 inches. Patient is presenting with apparent post-traumatic arthritis from fracture injury in left patella sustained approximately 3 years ago, which healed with little complication. Patient has a history of clinical depression and was prescribed citalopram as treatment, which she took for approximately 2 years before being withdrawn from. Patient has instead been going on walks as part of a group as an alternative management of her depressive symptoms, which she has cited as being very effective. Arthritic pain has been debilitating and on occasion has been preventing Dorothy from attending her walking group, which has been having an impact on her mood. Patient has claimed to be taking 2 500 mg tablets of paracetamol twice daily when the pain is unbearable, but has been experiencing no noticeable effect on pain. Due to the ineffectiveness of paracetamol, Dorothy has sought help for alternative pain relief. Dorothy was prescribed codeine for pain management, as paracetamol has had no apparent analgesic effect. Due to the increased risk of polypharmacy in the elderly, Dorothy was not given a prescription for drug combinations such as cocodamol. Although patient has claimed she is taking no other current medications, many over-the-counter cold and flu remedies contain paracetamol, which in excessive quantities can result in an overdose. Another risk is the patient being prescribed other medications without ceasing use of cocodamol first. If they also contain paracetamol, excessive quantities could be ingested. As codeine is a prescription-only medication, the chances of overdose are little as long as restrictions are followed accordingly. Dorothy has no history of asthma or any depressive respiratory illness and no history of head injury. Patient is currently abstaining drinking alcohol to prevent the reoccurrence of prior depressive symptoms and has no other apparent contraindications. Due to her age, Dorothy has been prescribed 10 mg tablets to be taken once every 6 hours when required. In the case of dosage being ineffective, as long as no adverse effects are present, the dosage may be increased under a doctor's advisement. Codeine is an opioid analgesic, meaning it produces morphine-like effects to cause pain relief. Codeine is a selective agonist for the mu-type pain receptors responsible for transmission of pain throughout the body, and produces a similar but weaker analgesic effect to morphine. Morphine actually has the same mechanism of action, but with a much stronger binding affinity for the receptors, which is what causes the stronger effects. The exact mechanism of action for codeine is currently unknown, but being partially metabolized into morphine in the body may be responsible for producing some analgesic effect. When the drug binds to receptors as an agonist, it activates the G protein in G protein-coupled receptors, which inhibits second messengers. This causes calcium channels to close and potassium channels to open, which, as seen in this image, reduces neuronal excitability and therefore reduces the transmission of pain signals. As well as for treating pain, codeine can be used for treating persistent coughs, congestion, respiratory distress, and diarrhea. Codeine tablets are absorbed in the gastrointestinal tract. In elderly patients such as Dorothy, absorption of most drug formulations are slowed, including oral tablet formulations. Absorption is still total, however, unless conditions are present that increase the elimination rate of unabsorbed drug, such as diarrhea. Codeine is widely distributed in the tissues, with a volume of distribution of between 3 to 6 liters per kilogram. Distribution of drugs in the elderly is significantly impacted by the associated decrease in plasma proteins, meaning more of the drug is free, resulting in a higher functionality. With less binding to plasma proteins, more of the drug makes it into the tissues where it can take effect. This increases the chance of toxicity in the elderly, as the same dose in an adult will have a higher effect in the elderly person. This is managed in patients like Dorothy by prescribing lower dosages. Codeine is mainly metabolized by liver enzymes. It is a prodrug, meaning its metabolites are active and responsible for producing analgesic effect. The decrease in activity of liver enzymes, along with the decreased hepatic blood flow associated with the elderly, increases the half-life of drugs in the body. This means the drug remains in the body for a longer period of time, meaning its actions last longer in older patients. Dorothy was told to take a lowered dose every 6 hours rather than every 4 to 6 hours, to minimize the chance of her taking too much of the drug accumulatively. Codeine is mainly excreted by the kidneys, with approximately 10% of what is excreted being unmetabolized drug. With age, kidney functionality reduces, which results in the drug remaining in the body for an extended period of time. This change, along with many other pharmacokinetic changes in the elderly, increase the risk of drug toxicity, which is why Dorothy has been given a lowered dose and been told to take it sparingly. Potential adverse effects of codeine include dizziness, drowsiness, nausea, vomiting, and constipation. In the elderly, common side effects of opioid drugs include sedation and mild cognitive impairment. It is important to monitor elderly patients such as Dorothy for adverse effects, as sedation, dizziness, drowsiness, and mild cognitive impairment can all contribute to adverse drug events, such as falls, which have a disproportionate chance of causing serious injuries in older patients. Other adverse effects of codeine use include tolerance and addiction. This is more likely to develop due to sustained use of the drug. Tolerance refers to the drug losing its therapeutic effects due to continuous use, requiring more of the drug to produce the same effect as the original dose. Addiction is the loss of self-control in relation to the use of the drug, where taking it is a compulsive behavior, even when the desire to stop is present. Addiction is common in codeine, as when the drug is broken down into morphine in the body, it impacts the reward centers of the brain, producing euphoria. Both tolerance and addiction are dangerous, as they typically lead to increased doses being taken, which consequently leads to increased incidence of overdose. A study from 2015 found that between 2000 and 2009 in Australia, codeine-related deaths increased from 3.1 to 8.7 people per million, largely due to accidental overdoses and multiple drug toxicity. A study from 2019, however, has revealed that since the reclassification of codeine to a prescription-only medication in 2018, misuse of the drug has dropped significantly, contributing to fewer deaths. In elderly people such as Dorothy, tolerance is less likely due to physiological changes directly opposing the chance of tolerance, while increasing the chance of toxicity. Addiction is difficult to identify in the elderly, as many of the typical symptoms are seen as normal in the older population. Withdrawal or aversion from social situations, which is common in addiction, isn't seen as abnormal in the elderly, as the increased mortality rate of friends and family leave fewer opportunity to attend social gatherings. Retirement removes the responsibility of a job from everyday life, which makes dismissal of responsibilities more difficult to detect. Tolerance is another symptom of addiction, but again, isn't typically present in the elderly population. The lowered ability to detect addiction in the elderly population can contribute to increased death rates. As addiction goes unnoticed and untreated, the chance of an accidental overdose increases. Given the heightened forgetfulness in the older population as well, there is a greater chance of them forgetting they had taken a dose and double dosing, which is a problem outside of addiction also. The inability to obtain the drug without a prescription, along with low prescribed doses, should work to reduce the risk of addiction in Dorothy, along with checkups and monitoring her use of the drug and any other adverse effects. Addiction should be easier to recognize in Dorothy through the indicator of social withdrawal due to her participation in a walking group. If Dorothy were to stop attending this group despite receiving pain relief, it would be an indicator of social withdrawal and therefore addiction. Although a patient has a history of depression, due to her management strategies and her general improvement, it is not seen as a risk to developing addiction. Dorothy should be monitored, and at if any point addiction or any other adverse effects are present, her prescription should be altered. Thank you.